Good evening, everyone. I'm Paul Sorajja from the Minneapolis Heart Institute in Minneapolis, Minnesota, and welcome to the latest edition of Nail It with Nadira. Tonight, we're going to be covering percutaneous mechanical aspiration. I'm going to do some housekeeping introductions, and I'll turn it over to Dr. Hamid. So this is a CME accredited activity. You can certainly look at the learning objectives here, which are evident for this activity. And it's eligible for 1 credit, which you can claim on our website anytime after you have participated and seen this activity. In terms of faculty disclosures, I had the pleasure of kicking this off and been joined by several of our colleagues here, Dr. Abdallah El Sabbagh, who has no financial disclosures, Dr. Nadira Hamid, and Dr. Sandra Sethi, whose disclosures are listed as here. This is where you can claim the activity on this website link here, which is on our website. And we'd like to thank Abbott, Medtronic, and Shockwave for supporting these CME webinars. This is how you do it if you want to claim credit. And then finally, I'd like to invite you all to come to our annual meeting, which is back in Austin this year, July 24th to 26th at the JW Marriott. This is the Operators Enclave, and really look forward to seeing you all there. So with that, I'd like to turn it over to Dr. Hamid, who's going to be kicking off tonight's webinar.
Thank you very much, Paul. We're going to share the slides now, Abdullah. But first and foremost, I would like to say thank you so much, every one of you who has joined, friends and colleagues, and taking time out from tonight to spend it with myself, Paul, and 2 esteemed colleagues, Dr. Sanjum Sethi and Dr. Abdullah, on Nail It with Nadira. And today we'll be talking about percutaneous mechanical aspirations. These are my disclosures as mentioned. And for today, the next hour, what is the agenda that we're going to talk about? We want to bring you the landscape of infective endocarditis. What's new, what's in terms of management, and how we can tackle these patients with IE. We're going to go through 3 interesting cases, 2 of which will be right-sided and 1 of it left-sided. And we'll close it with a presentation by Abdullah, who presented last week at a late-breaking presentation at TCT on Clear IE registry. And for those of you who don't, in terms of the Clear IE, what it stands for cardiac lesion extraction and aspiration registry for infective endocarditis. So without further ado, I'd like to introduce Sanjum Sethi, who will introduce you the landscape, and followed by the first 2 cases.
Yeah, no, I really appreciate the opportunity to be on this webinar and for bringing attention to, I think, something that has been a little bit neglected, I think, in our field for a little bit of time. And we have some emerging technology, I think, to help some of these patients. And we're really going to be focusing on the endocarditis patient, and really have had a lot of fun the last couple of years working with Abdallah on a registry, which you'll see at the end, and sort of talking about strategies for these patients. So with that introduction, the landscape of endocarditis really has changed. We have, or traditionally, I should say, we had really young patients with adult congenital heart disease or valvular heart disease that were affected, but now there's a whole host of different patients. So you have those who have drug use, an aging population with more immunocompromised, as we come up with more devices and more indwelling catheters, prosthetic valves, different devices prior surgery. So there's a whole host of reasons now why patients may develop endocarditis, and different reasons why we may need to intervene, and also different patient populations. It may not just be the young patient anymore. It may be older patients or patients who are of cardiac surgery prohibitive risk, so to speak. And there is certainly gaps in management of infective endocarditis. Traditionally, there's been certain antibiotics that are used, as well as surgical options. But I think the catheter-based approaches are evolving, and something we're really going to focus on in this particular presentation. So I'm going to, we'll start with a sort of a reflective case. And these case presentations are really meant to be high level and illustrate some of the concepts. And we're going to dive a little bit into some of the techniques and technologies. I'm really privileged to have Dr. Sorajja and Dr. El Sabbagh, who've done a lot of these cases on the call with us, and Nadira, who's supported more than her fair share day and night for me and Dr. Sorajja. This is a 28-year-old woman with a history of IV drug use, presented with fever and chills 5 days after her last use. And as you can see here, there's a significant lesion on the tricuspid valve. I think this is something that all of us, when you see this in the echo lab, you get excited that that's quite a large vegetation. And you can imagine that something like this may not respond to antibiotics, especially if it's an aggressive microbe such as Staph aureus, which it was in this particular case that we found out. And the issue with these patients is not only may they have a large vegetation, they may be presenting with embolic phenomenon to their lungs. If they have a shunt, it may even go to the left side, and then certainly they may have persistent bacteremia, sepsis, and positive blood cultures along those lines. And you could see that antibiotics were started in this particular patient, but despite several days of antibiotics, she was still persistently bacteremic, having fevers, having positive blood culture. So antibiotics alone may not work, and we'll talk about some of the reasons along the way why that might be. And so the question is, how do you approach it? So I think we can go to the next slide, because I think we're going to talk about some of the ways that we can approach it aside from the traditional surgery as well as medication. So this was a really nice review in JACC, and we have a team now, or an endocarditis team. We call it I think substance use related endocarditis. And the idea is that you assemble a team of experts that are going to be working in a multidisciplinary fashion for these patients. I think all throughout cardiovascular disease, we've been moving more towards this team-based care, because we understand that not a single individual may have all of the expertise components that you may want for a particular patient. So for somebody like this, you want to have an interventionalist, a cardiac surgeon, an infectious disease specialist, addictive medicine, I think, and psychiatric medicine, social work are very vital in this particular population, because I think one of the issues that we'll get into is that traditionally, even when these patients were offered surgery, the rates of having recurrent endocarditis because of some of their psychosocial factors was extremely high, right? And I think we all know that prosthetic valve endocarditis is even worse than native valve endocarditis in terms of ability to treat it effectively. So I think approaching this from a team-based approach is of vital importance.
Sanjam, how do you assemble the endocarditis team? What's the algorithm like in your hospital?
Yeah. So I can tell you what we've done, and I really appreciate. I think some of my colleagues are on the call. We've really had the call goes in. There's a group chat in Epic that we're all on. A call will generally go in either through the infectious disease or through general cardiology. We'll then have it sort of pasted onto the chat, and then we all get together and discuss the best options for those patients. And having everybody on that chat is very helpful, because you can rapidly say, okay, well, we think this person might be appropriate for surgery. Maybe this person needs medical therapy for X amount of time. Maybe this person would be good for an upfront catheter strategy or delayed catheter strategy. And I think, and we'll get into some of the evidence, right? The evidence has really been lacking. So I think a lot of this has been clinical gestalt of how to deal with these patients. But you really want to capture those people who have a vested interest. So I can tell you that it took a little bit of searching to find the right general cardiologist who would fit in with our group in our institution. So I think you really want to have people who are invested and excited about it and really want to take ownership and take care of these patients. And I think that collaboration also brings together different avenues for research and other collaboration. So I think there's a lot of value to it. So we'll talk a little bit about percutaneous mechanical aspiration. I think the role for it is still evolving. So I think, as I've said a couple of times, we understand that all these patients should be on appropriate medical therapy. and certain patients will be appropriate for surgical intervention. For those who we think surgery may not be the best option, we do have catheter-based approaches where you can effectively remove the vegetation and use it to for a variety of reasons. Some patients may not need anything further beyond that. Some people, it may buy them time to be able to clear their infection to make them better surgical candidates. For some patients, it may be a bridge to eventual recovery and valve replacement. One of the ways that the aspiration works is it disrupts the biofilm. As you can see here, there's a biofilm around the bacterial colonies. So by disrupting that biofilm and removing some of that material, you not only can increase the antibiotic efficiency of whatever residual material is left, you may also decrease the embolic potential for those patients who have had multiple septic emboli from the left side going to parts of the arterial circulation or the brain, or from the right side going into the lungs. Lung abscesses, brain abscesses, spinal cord abscesses are as we all know, really difficult problems to treat effectively. When we think about what patients are appropriate, we really want to dive into vegetation characteristics, device characteristics, and patient-related factors. And all of these may play a role into who may be better or worse for a catheter-based intervention. Let's talk about vegetation characteristics first. And if you go to the next slide, we want to talk about the location, the anatomy, and the pathogen. So primarily, especially for those who are starting out, right-sided endocarditis is, I think, the easier approach. Generally, it's on the tricuspid valve or near the tricuspid valve. There's a straight shot from the neck with a little bit of bend from the groin you can get there. I think for like the couple of operators we have on the line here, left-sided can be also approached successfully. I think there needs to be a little bit more expertise with that. And you can go from a transeptal approach if you're going to the mitral valve. You can go retrograde if you're going to the aortic valve. And so I think we may talk, maybe Abdallah or Paul can comment more on some of the left-sided work that they've done. But you want to understand, is this something that you have the skill set to approach and how you're going to approach it? And then anatomy. So when you
before that, Sanjam, can you comment on those vegetations right under the tricuspid valve?
Yeah, it's a really good question. It's a difficult location to reach, and I'd be happy to hear your thoughts on it. It's difficult to make the bend on the catheter right under the tricuspid valve. I mean, you kind of have to do some gymnastics with it. It also depends on how mobile it is and how much sort of it might be peeking up into the atria. But getting into that RV and sort of stabilizing it can be a little bit challenging. I don't know if Paul, you have any thoughts on that.
Yeah, no, Sandro, I think it's a great point. I think if it's subvalvular, it basically warrants an IJ approach. It's pretty hard to reach transfemorally because of the curve and offset of the IVC. But from an IJ approach, it's pretty easy to reach because first of all, you have shorter distance with the catheter, so you have a little bit more catheter length, but then the orientation towards the valve is a little bit more favorable. And you can even go up and grab stuff in the pulmonary artery too, if you wanted to. Abdallah, do you agree with that? Or
Yeah, yes, and I would add to that one additional technique is actually aspirating on the way back. So sometimes it's hard to get to that subvalvular space in certain situations. So I usually just cross, ramp up the aspiration flows and pull back and see if that comes off or not. So that's another tip.
Matt Wiesenen, who has a lot of experience with this too, actually just put in the Q&A that going subvalvular from the IJ it sounds like it's what his favorite approach is too. So thank you, Matt.
Yeah, and that's a great point. Nadira, do you want to comment on visualizing that area and what views we should be looking out for? Because I think imaging to get there is really key.
Yeah, thank you, Sanjam. No, it's a great point because we really need to see where exactly in the subvalvular, is it the quartz or the papillary muscle, how far deep into the RV. And, I think in terms of views, I think like any tricuspid imaging, from the mid to distal, but I find most particularly in the subvalvular, going to the transgastric and deep gastrics are really the best views. And I think we had a case, Sanjam, back in Colombia, where we really went to the transgastric. And I remember it was stuck on the cords and you were trying so hard, that small vegetation. And in the end, we gave up. I remember that case very well because it was really stuck on the cords. And so really, I think we went IJ as well for that case. So I think using all views, but subvalvular, I love the transgastric and the deep gastric views to really visualize the subvalvular and to ensure that you don't get any complications in terms of torn cords or the pap muscle, any interaction of the catheters with the subvalvular apparatus as you do the angiovac.
Yeah, it's a really good point. I mean, especially when we first started, and this was several years ago, we were sort of worried: are we damaging the valves? Are we damaging, native material when we do this procedure? But in all of the past studies I have sent, I have not gotten a report back that it was valve tissue. It's always been sort of pure vegetation. I don't know if your guys' experience has been any different.
Yeah, Sanjay, I completely agree. The devices we use are pretty gentle.
Yeah.
And I have taken out valve tissue inadvertently. In my opinion, that is that if it comes out with a gentle device, it's not a functioning valve, and it's not meant to stay there. And so it's pretty gentle, and it's pretty rare, I think, to have valve damage.
Yeah, and I think there's a point in some of the earlier work that where tricuspid regurgitation was worsened at post-procedure, because I was primarily only studying the tricuspid valve. But my suspicion is that that's actually unmasking already degenerated valve. The vegetation is actually sort of keeping that valve more competent than it really is. And I think it's not actually causing TR so much as it just unmasking TR that was pre-existing.
Completely agree.
So when we talk about anatomy, so there's better anatomy and not so good anatomy, and I think some of this may depend upon your level of expertise and with the devices, but certainly things that are large, mobile, and acute are going to be things that are easier and more favorable to get. So the one on the left, if you have done this for a little bit of time, you get the catheter there close, you should have a very short case and get most of that material out. It tends to cleave where it's more mobile, and that's sort of the where the material will cleave off and come into the catheter. Stuff that's on the right is a little bit more challenging. It's when it's sort of diffuse and chronic, and it can be more adherent. The devices don't have something as much to grab onto, and you can sort of grab onto the apparatus, but not actually extract a lot of that material. And especially in the beginning, you may want to walk away from a case that's on the right. It all depends on your situation and what the risk profile and clinical indications are for the patient. But certainly the left is definitely more favorable.
Sanjay, are you going to talk about timing in terms of like, do you wait for emboli to happen? Or, I mean, can you tell us a little bit about that? Or if emboli happen, is it too late? What is your view on that?
Yeah, no, I'm happy to discuss it, but I'll let Abdallah take a question here.
Okay. Abdallah?
Yeah, so it's a great question. We don't know the right answer to it. Obviously, we still do what was done historically in the surgical population, which is if there's vegetation more than 2 centimeters, and that's what's reflected in the guidelines, right? And if there's ongoing recurrent pulmonary embolism or evidence of right-sided heart failure, that's the timing of intervention. But like everything in valvular heart disease, we're learning more and more that waiting is not good. And so I think the field, just like in endocarditis, in that a Korean study that showed probably earlier intervention is the way to go. And I think that eventually this is where this field is going to head towards. There's no good in waiting, especially if it's one, Staph aureus, which is the common bug. Two, if the vegetation has high risk characteristics, it's more than 2 centimeters, large, mobile. I just don't think that we should wait that long, but more to come on that.
Yeah, that was perfect. I don't think there is an answer on what to do. I can tell you functionally the way we do it is that we leverage our team-based approach here. So if the infectious disease consultants agree that it should be done, if the surgeons think that it's not an operative candidate, that's when we proceed. So we make it a combined effort. But I think we as a group are moving towards earlier because we're seeing the benefits to our patients in terms of even simple things like decreased length of stay, getting out of the hospital faster, getting into rehab faster. I mean, those are all important factors for long term for these patients. So and certainly we usually, like Abdallah said, there's usually something in terms of either persistent bacteremia, embolization, or vegetation size that would drive us. And that's a perfect.
I have to tell you, Sanjay, it's actually interesting. So when we've had some of our patients and we've done this. They're very excited because they think, well, okay, I'm done. I can leave the hospital tomorrow because you've debulked me and you've got me on antibiotics. Not so simple, but sometimes accelerating their discharge is what they want to. So.
Yeah, absolutely. And so I think this is a perfect segue to the patient-related factors, right? So I think there is a sweet spot for this. I think that when the patient is truly septic on 3 or 4 pressors, you may have missed the boat. I should say, or refractory septic is what I should say. And I do think that having some indication of what their stroke risk is, what their pulmonary reserve is, what their clinical stability is all very important. I think those patients who are either having trouble clearing their infection, having low pulmonary reserve, frequent emboli, big sizes, should go on the earlier side rather than later, because you don't want to wait until they're so ill that any kind of manipulation may tip them over and make them refractory. We see from the case series, at least that exists in literature, that when you go late or too late, I should say, patients don't do as well.
And then who has seen those transient hypotension or sometimes chills if you're doing it under conscious sedation once you kind of disrupt that vegetation? Maybe you want to comment on that. Has anyone seen excessive hemodynamic compromise with that?
I mean, we certainly will see transient bacteremia, or at least the effects of it, right? Patient may be on a little pressor, then they leave. But most of that usually resolves in 24 to 48 hours, at least for us. So I do actually consent to patients that you may get slightly worse for a day before you get better. So we have seen it, but I'll be honest, the degree of intra-procedural, post-procedural sort of SIRS-like phenomenon is variable. I haven't found a good way to risk stratify or predict it. I don't know if you guys have.
So Abdallah, I just have to ask, so you conscious sedation, so are you using transthoracic ice, or are you being really mean and putting a TE probe down with these people awake?
No, I still
how
do
are you doing
TE
this?
guided. I still do TE guided general anesthesia, but there are centers that do ice guided with
Okay.
conscious sedation.
Yeah.
So
Okay.
and they see the chills. Sometimes we see them after the procedure when we extubate them, but and everyone's screening for PFOs. What do you do for PFOs in these cases?
If there's a good PFO, then I think that a discussion around cerebral embolic protection becomes important. But otherwise, without it, I'm obviously not too concerned.
Yeah, Nadira, can you comment on ice versus TE?
Yeah, so I mean, everybody, one thing, 3D ice has been revolutionary, or 2D ice, especially for these cases. Would you find my concern, without the imager there, holding all the devices, will you be able to do both at the same time, imaging and also manipulating the angiovac to the vegetation? So that's one concern I have. But I think ice imaging can certainly be really helpful for these patients. I think in terms of Sanjum access sites as well, I think that's, whether it's suitable, I think that's a consideration. TE, I think it's, if you want to go the transgastric view, that'll be very helpful. Ice imaging is really good because you're right there, depending on where the location of the vegetation, I would say. So I think depending on the patient profile, patient selection, but I still think TE would be really helpful and general anesthesia for these cases.
And
I think ice might be a little challenging for far field imaging, especially if you've got things really subvalvular.
Yeah.
But given the size of these vegetations, I actually think the 4D ice, you'll be able to see them pretty well.
Absolutely.
In a lot of cases. So
the only thing I would add, Nadira, is if you're doing angiovac on me and putting a 26 in my neck, please put me out. General anesthesia, TE. So that's the only thing that I would say.
I hope I don't have to do it.
No,
don't
All right.
worry, this might just hurt just a little bit.
Yeah.
And it's a great segment to device characteristics,
Exactly.
which I think, which I think the three of you can speak more to this, like which device do you choose, and, I think the three of you, please describe more on this.
Yeah, I'd be happy to hear Paul's thoughts. I know Abdallah and I are relatively aligned on this. So there are 4 catheters that are out there that people have used. I'm not going to say approved because some of these are off-label usage. The AngioVac does have a breakthrough designation for this from the FDA. And basically, the systems vary. And the things that you want to think about are, can you go to the next slide for a second? So the things you want to think about are cannula size and reach, maneuverability, contact, aspiration force, and blood loss. If you go back for a second, you'll see that there's these are the 4. And they have different characteristics when it comes to those things. So the AngioVac and the AlphaVac are from AngioDynamics. They have a similar kind of cone funnel shape at the end. The AngioVac is continuous aspiration with a reinfusion cannula. You'll need a perfusion setup there, right? So that's why your setup would be anesthesia, TE, perfusion, and you would add it. To me, though, it's the best device for this because you have continuous aspiration, high volume aspiration. You can really get good clearing. I think when you disrupt some of that biofilm, you can have septic emboli and other issues. And you have reinfusion after it goes through a filter, which you'll see on the next slide. AlphaVac is similar design, but it's a single pull without reinfusion. The FlowTriever catheter is a manual aspiration pull, and then the Penumbra is a continuous aspiration without reinfusion of blood. All the 3 that are those 3 that I just mentioned are really PE devices that are being repurposed for this particular situation. The AngioVac device was initially designed for intracardiac thrombus. I don't know if you guys have more comments than that.
I like the continuous flow aspiration in these. So I tend to use AngioVac for most of them just because of the embolic risk to lower it. So I tend to approach these vegetations with the flow on and ramp up until I debulk most of the vegetation. And then what we've been recently doing is actually turning down the flows to a lower speed and then just kind of cleaning up on the valve a little bit to quote unquote debride. It's a strong word, debride, but just imagine that on low speeds, just to kind of take out as much vegetative material as possible. So that's where some of the advantages of the VAC are in.
I'd agree with you, Abdallah. I think the perfusion requirement, we don't blink at that anymore because we're used to doing ECMOs in our patients. And the amount of blood that you actually have to suck off, it's very important to return that to the patient. So having the circuit where you can return the blood to the patient, the AngioVac, I think is really, really helpful. And I also like the steering capability. Nothing is completely perfect in terms of how you want to interact with the valve, because none of these were designed to be valve technologies. So the steering isn't exactly designed that way, but I think, especially the AngioVac has a really good steering capability. I don't have any personal experience with the flow retriever. I've used both Alpha and Penumbra, but I tend to gravitate more towards getting the circuit out and doing the AngioVac. Sanjam, what do you think? What is your preferred?
Yeah, I'm with you. You made a good point about the blood return. I mean, these patients will often come in anemic because they're infected and they have bone marrow suppression from the bacterial infection. So I think that that blood return can actually be important when you're starting with a hemoglobin of 7 or 8 or 9. And I completely agree. This is the setup for the AngioVac that you see on the screen here. I completely agree that having that continuous aspiration, steerability, plus that return cannula makes it an attractive option for these patients.
One thing that always comes up is if you embolize some septic material and the patient becomes hypoxic, what do you do, Sanjam? Do you keep the steer with the AngioVac or do you switch to another device?
Yeah, that is, I think, one of the downfalls of the AngioVac is that if you want to go into the lungs, I don't think it performs quite as well there because I think the flows are just a little bit too much for the pulmonary circulation. So I will tend to switch to another device if I'm going into the lungs. I don't know what your guys' thoughts are.
Yeah, same.
This is a little schematic here of an IJ approach to one of these. So you can see the catheter being introduced. You go on flow just before you have contact, and then put it right near, and then sort of ramp up your flows as you approach the material. And you could define success as greater than 70% or less than 1 cm residual with no complications. I think that's actually a very good segue to, I often have Nadira, whoever my imager is, sort of talk about, when am I done? When do you stop aspirating? How much is enough? So we put on there greater than 70% or less than 1 cm. But as you know, in day-to-day practice, that's sometimes a judgment call.
So Nadira, maybe just a quick comment on the imaging sequence. Do you have this instructional interventions, like this common language that you use?
Yes, I mean, kind of, once you guys assemble it and you advance it, for the right side, it's easier. And really guiding, we'll show you a case, guiding using all tools, whether it's 2D, 3D MPR, to really, because it's the tricuspid, where exactly is the location of the vegetation? Is it on the anterior leaflet, posterior leaflet, or septal leaflet? And really, in terms of trajectory as well, the 3D really helps with trajectory of the catheter, so in terms of which devices to use and the catheters to use on your end. And once you aligned it, the trajectory, and that's where you aspirated. So I think using all tools, like you can see here in the imaging here, from the, from 0 degrees, and then bicable view as you enter it, whether is it from the jugular or from the IVC, and really guiding. So exactly like any intraprocedural guidance to where the vegetation is. So baseline imaging is really important to identify where. And so it helps for you guys in terms of pre-procedural planning as to which access to which catheters to use and which devices as well.
Let's go to the next slide. Yeah, I mean, this is another case example here. Like that patient, you can see, successful removal of clot, and then you can see here at the end what kind of material you get out. This is very common, haul, so to speak, and then obviously make sure you send this over to your microbiology so we can make some decisions about antibiotic management. You'll be surprised that sometimes not all of the bacteria or other pathogens that are present in the bloodstream in the bacteremia. So as from the material, you may get an additional microbe or source that might help you tailor your antibiotics more effectively. And then hopefully you'll get sepsis resolution afterwards. And we see that quite commonly. Next. Just an example of sort of what happens with the white count there. Next. So I'm going to go case 2 quickly because I want to make sure we have time for Nadira and Paul's excellent case. So it's a 32-year-old woman with a history of IV drug use, presented with fever and chills, and then left AMA, came back with worsened symptoms. And you can see here, again, pretty significant vegetation, sort of adherent to the valve there. And you can see a significant amount of, it looks like decent amount of TR, would you say? Yes?
Yeah, and what's significant here from, imaging standpoint, the color Doppler, you can see the jet actually within the leaflet. So you know that there's actually injury to the tricuspid leaflet, as opposed to the first case where, there's not much injury just on the leaflet, but you can see that, it's the vegetation is affecting the leaflet itself. Would you agree with me, Sanjum and Abdullah and Paul?
Yeah, absolutely. Absolutely. So again, similar, setting up your shots, and you can see that picture on the bottom is so great. Go back one, where you can see that catheter right there, right at it. And you can understand that just with a little bit of advancement, you'll be able to catch that. And as you ramp up your flows, actually, you create, the initial name for this catheter is vortex. You create a little effect there, which will help to facilitate the catheter being aspirated towards your device. And again, here you can see a very significant haul, so to speak. I want to take one quick second to and clearing of the valve. I want to take one quick second to also talk about, one other approach that is quite common is for lead-related endocarditis or infectious endocarditis. And that's a situation where we work in concert with our EP colleagues and, or do this in concert for lead removal. So that's just something else to keep in mind.
So just a quick comment.
I'm just looking. Oh, sorry.
No, go ahead. Sorry, Paul. Go ahead.
No, I was just looking at your last slide and just looking at how mobile that vegetation is coming down from the SEC. Do you ever create ventricular standstill to engage the vegetation, or you just don't find that necessary?
On the right side, I've not found that necessary, but I don't know if you guys have had to do that.
No, I was just thinking out loud. I was just looking at that vegetation and how mobile it is, and I was just curious if we might be more effective if we actually did some adenosine or something to kind of slow it down and then go in and grab it.
Yeah, it's a great question, especially because some of these patients will be pretty tachycardic, right? Because
Yes.
they ongoing sepsis. So it's a very interesting point. I think though what happens as it's moving around, you create that sort of whirlpool effect, and that kind of stabilizes it a little bit, and kind of it's like an attraction almost.
Okay.
I don't know if you felt that, right? I mean, when the catheter gets close, you turn up the flows, and it kind of just sucks into it.
Yeah, there's a lot of excitement and it starts chugging.
Yeah, right. I tell my fellows, like, you feel that?
Yeah, and then it's amazing how this picture in the top looks like my Dyson vacuum cleaner.
One quick comment here is that which is going to contrast what Nadira is going to show, and we'll talk about that on the left side, is most of the time if there's worsening TR, it's usually tolerated, and that's good. Even if there's worsening TR here, we're uncovering a perforation. It allows for time to send the patient to rehab, get the addiction treated, and then undergo surgery. So as opposed to just going straight to surgery and then running the risk of reinfecting the valve with continued drug use.
Historically, and it's still done to this day, and Hartzell Schaff at Mayo taught me this many years ago, is that people would just cut out the valves, so to reduce the risk of recurrence, you just take out the whole valve. And patients can live like that. When they're really young, they can.
Yeah, so I think for case 3, I'll turn it over to Nadira, who will take us through this fascinating case.
Thank you so much, Sanju. Those are two great cases of right-sided. And the third case is something that we actually did 2 weeks ago. It's a 58-year-old gentleman with previous mitral valve repair and tricuspid valve repair, and had a redo sternotomy for unknown reasons, but suddenly then had a mechanical MVR with an Onyx just recently in July this year, had a maze and atrial clip, but had recent recurrent CVA. The most recent was actually in May this year, and had a mechanical thrombectomy and had proximal atrial fibrillation. And imagine this is a significant comorbidities at the age of 58 years old. Now, this time presents to our hospital. Next slide.
And not to interrupt you, Nadira, but this is exactly what we're talking about, that, this is this changing landscape of what we see, right? Look at how many devices and surgeries and procedures this patient has had, right? And what would be how attractive would be a redo operation, somebody like this, right? And he's only 58, right? So clearly there's an unmet need.
Absolutely. And then this time, he came into our emergency department with another left-sided paralysis and right-sided gaze, showed, acute stroke and occlusion of his proximal right MCA, underwent emergent thrombectomy. And fortunately for him, his deficits actually resolved. And so he obviously underwent cardiac workup, transthoracic and TEE was performed. And this is what was revealed. So you can see here that on the left-hand side, the mechanical valve, you can see the tilting disc working well, but you see a lot of multiple echo dense masses. And 3D, you can see in the middle image, this echo dense mass sitting on the sewing ring all the way from 6 o'clock all the way to 12 o'clock, anterolaterally. And you can see on the right-hand side there as well, really a lot of these echo dense masses. He was not septic, his blood cultures was negative. And so really this was referred to us cardiology as to what are the next steps. Next slide. In terms of, whether he has regurgitation of due to this, there wasn't any much paravalvular leak, just traced to mild transvalvular leak physiologically. And it's just these new findings. And so, Abdullah and Sanjam, what do you think your thoughts are, and what do you think the next steps would you do?
So, Sanjam, do you want to comment, or do you want me to go for it?
Go for it.
Okay, no. So on the left side, again, we talk about timing of intervention, right? Strokes and then vegetations on the mitral valve more than 1 centimeter. Those are high risk for recurrent strokes, and so multiple reasons here to do PMA. One, for lowering the stroke risk, and he's a higher surgical candidate, and those are large vegetations that are mobile. Two is we don't have a diagnosis, right? It's the cultures were negative, so that also helps with that. So I would push for PMA. Now, some people argue this is a prosthetic device, and yes, it's a little bit of a gray zone on what to do chronically with those. But I would still, for at least diagnostic purposes, to see what this material is, and then and disrupt this ongoing recurrent CVAs. So.
All right. So absolutely, we went for next slide, the PMA. And in terms of, the steps, what are the next step? I think with his recurrent stroke, obviously in terms of embolic protection would be the first step of the procedure, which I'm sure Abdullah and Sanjam would agree. And, there was some difficulties, Paul, I remember, when you were trying to insert the Sentinel device. Would you like to comment on what you see here?
So it was one of these situations where I went up to meet the patient, and I looked at the patient. I thought, you know what? I really need to do whatever I can to reduce the risk of stroke. Strokes have already happened. I looked at the arms. I said, well, guess what? You're getting a Sentinel on each arm. And they said, thank you. So, because we talked about it, because it's just, what are we doing here? And so you can see here, Nadira's put the slides of the Sentinel deployment. It was actually relatively straightforward when I found out where the origins were. But one of the challenges from the right side was that it was almost a bovine. You can see there's a little bit of a bovine origin on the anatomic right, and then just coming across. Eventually, it took a little bit of finessing, but getting them both in. I hope you show a slide with them both in.
Yes, the next
We
slide,
eventually did
right
get
here.
there. Yes, there it is. So, yeah, and actually, what I did is, if you look, one device is going to the opposite side, and the other device is coming across, and it worked out well. So
That's right. And once he placed that in, and then we move along, and I told him that you have a surgical patch across the interatrial septum, and he gave a big sigh, but we proceeded. And so transeptal puncture with the Baylis, and of course then went ahead with the balloon septostomy. And the next slide.
So Nadira, just a quick comment here, and I would like to hear what Paul has to say. So the transeptal puncture, after multiple lessons and mistakes made, I think the transeptal height matters here. Just if you look at the curve that's made with the angiovac, I think if you aim for 2.5 centimeter height, just
yes.
posterior mid, I think that would help. The other thing is, what I did, and that may not work for this very thick patch, is I sometimes just go up with an upfront safe sept, and that goes to the left upper pulmonary vein, creates a rail from the septum to the left upper pulmonary vein, and allows all the exchanges without interacting with the vegetation. So those are things to kind of maybe just avoid dislodgement.
Abdallah, your points about the transeptal location is very important, because we have a single curve system. So we don't have double curves, so you can't correct an aorta hugger if you needed to. And so anticipating where that single curve needs to be placed And that's where someone like Nadira is really good about drawing a 3D view and showing that in this transeptal point, we know we only need a single curved steer to reach the vegetation. And that was part of the planning as well too. Yeah.
That's right. And so once we determined the spot of the transeptal, we did a balloon septostomy, you can see on the left-hand side. And then, Paul, you exchange wires and try to put the angiovac catheter, on the middle side, but there was something stuck there. And I think that's when you did a balloon assisted tracking on the right-hand side here. And Abdallah provided this next slide as to what balloon assisted tracking is.
And so just to kind of clarify for the audience, the outer when we insert the outer cannula with the dilator inside of it, for the 22 French angiovac system, that dilator is significantly smaller so it leads to the catchment of that outer cannula on the septum. So hence the need for balloon assisted tracking like we do for the radial artery to allow for a smooth transition. So this is an example of it. So I don't know if Nadira or Paul, you want to comment on that?
No, we would have never gotten across without the balloon assisted tracking because the septal patch was so thick. It wouldn't matter how we dilated, the transition would have been too great. So credit to Matt, our angiovac rep, who walked me through this to make sure I was doing it right. And so it went across really well.
Yeah, so this is an example. We just put a 7 French sheath at the sidearm and then over the wire put the 12 French balloon, extrude it through the distal end of the cannula and then inflate it and then push it across, just like the radial artery.
Yeah.
And once you get across there, that's where I start working. So you can see here using 3D MPR, which is really nice, where I just put the crosshairs and tell him where to move the angiovac to. And I tell him just sweep across and vacuum across from 6 p.m. all the way to 12. And you can see the left image, the middle image. Abdullah is moving. You can see on the right side of the image as well. You can see yes, he moved across the angiovac system all along across the sewing ring from 6 p.m. all the way to 12 o'clock position. And then next slide, and Paul was like, is there any more? And so this is when I said, yes, if you see on the left-hand side, there's actually a flicking at 4 o'clock position remaining there. So I brought my crosshairs to 4 o'clock where he then navigate the angiovac system to 4 o'clock. You can see in the middle image, he's navigating across down to 4 o'clock. And that on the right-hand side, you can see that's where he is. And you can see on the next slide, when I switch back from 3D to 2D, you can see on the left side image, really nice. You can see the vegetation within the angiovac system there. You can see, and on the right hand side where it just got suctioned out. So this switching back from 3D and 2D really helps, and the 3D MPR saves time, gives him the visual in terms of where to navigate around the sewing ring. So typically, like your mitral PBLs, using that same concept for him to navigate through to sweep across and get the vegetation. Next slide, Abdallah. And so, we sweep as much as we can. You can see on the left-hand side, really clean out as much as we can. I think we got pretty much all of it. And at the same time, there wasn't any change in the tilting disc, the transvalvular regurgitation. There you can see on the right-hand side that the iatrogenic ASD, but left to right shunting, but we left it alone. We didn't put any ASD occluder across in case if there's any further need for further intervention, and there was no right to left shunting or bidirectional shunting.
It was so much fun. We were hopeful in a cheeky way that maybe we get to do it again. So we left the ASD there open
and an infected valve. I think I wouldn't add. Probably all of us would not do add a device. One thing did you get any hypotension, Paul? When you started?
The patient tolerated it pretty well. And then the other thing is, if you're looking at the NPR images, so what Nadira showed earlier, we talked about, how, reaching across, you have a single curve, and I had a little bit of an aorta hugger, but it was still able to reach. And I think to your point about having the sheath, the transeptal a little bit lower, help with that. Because if you have too much height, it can go against you. Sanjay,
Yes.
do you agree? I just want to make sure, I have a very limited experience here, but.
No, I absolutely agree. I mean, I think adequate positioning is so vital, right? Because it's one curve, right? You can go from 180 to 10, but it's only in one direction. So if you don't have the appropriate length, you're gonna be too curved. So definitely.
Exactly. So sometimes we get hypotension, especially if they're regurgitant or predisposition to get hypotension on the left side. So I usually tell the anesthesiologist to pre-treat with some inotropes or vasopressors, and then I start at slow ramp up. I always use continuous suction on the left side and keep it going. The other point that comes up all the time is, where do you return the blood on the left side when you're doing left-sided cases? So for me, the approach is I almost always return to the vein, because they're short runs really, and they're tolerated. But in some patients who have concomitant valvular disease or stenosis or whatnot, who may have profound hypotension, or they've had a significant stroke that we don't want hypotension, sometimes returning to an artery just avoids that hypotension altogether. So that's just a little bit of a tip. I don't know what the others do.
The question that was in the chat, that was exactly the question in the chat. So we've going to do venous as well, but your points about artery are absolutely well taken.
So chronic antibiotics for this patient, or?
Yeah, so if you go to the next slide. Sorry, not sure what happened there. So there you can see on the left-hand side of the picture, and the pathology just came back, actually consistent with endocardial vegetation. There was negative for any bacterial fungal, and so the ID is continuing long-term antibiotics on her. Blood cultures are negative, and so she's on long-term antibiotics.
It's a great result, guys. I mean, that's
it really is.
That may have just had recurrent strokes until one was debilitating, and that would have been sort of the end, and you may have really extended the quality of life.
Yeah, and the surgeon who referred us a patient just begged us to help, because going back in and fixing this was, as you pointed out earlier, was just a nightmare. Yeah.
And so for left-sided, is there any data on this? And so the data you can see, next slide, Abdallah, sorry. The data have always been on the right-sided. The most recent was from ESC 2023, it's a class 2B in terms of debulking on right-sided. And so really the left-sided, there's no data. But we certainly feel that there's a need, I think we need data on this. Obviously, it's something that I think Abdullah and Sanjay will work on, and something to look forward to.
Awesome. So in the next a few minutes, I'll just go over some of the results of the Clear IE that Nadira mentioned earlier, which is really that multi-center registry. We had to start somewhere, right? The field needed a jump start, and before what comes up all the time is, well, we need a clinical trial. Sometimes clinical trials done too early on novel therapies, especially in a sicker population, can be a little bit uncomfortable, right? We don't know how we perform. We don't know an idea about safety, feasibility, etc. So this registry was intended exactly for that, which is to assess the safety and efficacy of PMA in right-sided infective endocarditis. So we really excluded left-sided cases, and it was 19 centers from across the U.S. With the 256 total patients included in the final analysis. So just a few words on the cohort. They were younger patient population. Median age was about 43, again driven by the IV drug use, which is constituted about 50% of the cohort. The majority were bacterial infective endocarditis, and to no surprise, staph was the most common bug. And the majority of the patients had persistent infective endocarditis, either large mobile echo densities of more than 2 centimeters, or had recurrent pulmonary emboli or persistent positive blood culture. So really a sicker population. And from a procedural standpoint, the majority of these procedures were done using the Angiovac device. The median reduction of the vegetation was from 24 millimeters to 7 millimeters. And then most were done under general anesthesia and TEE guidance. So the key endpoints of the study were the following. We defined procedural success as a reduction of more than 70% of the vegetation or less than 1 centimeter, which is that size cutoff where the antibiotics tend to work effectively on the right side. So procedural success was achieved in about 89.4% of cases, which is a pretty good number. We defined the primary efficacy endpoint as achieving culture clearance, meaning negative blood cultures after the procedure, and that was achieved in 92.4 of patients. And then finally, we defined the primary safety endpoint as in-hospital, the composite of in-hospital death, new pulmonary embolism, and emergency surgery. Now, mind you, there was no protocolized systematic imaging post-procedure to define the timing of the pulmonary embolism. So that's a little up in the air a bit. But the primary safety endpoint was 18%. And when we looked at the characteristics associated with these outcomes, having bacterial species, having no residual vegetation, and having an immunocompetent state as opposed to an immunocompromised state, those were all associated with successful culture clearance. And then the characteristics associated with the worst outcomes were hypoxia, presenting with hypoxia. Again, to the point of, are we doing those too late? So hypoxia was the strongest, had the strongest association with the worst outcomes. Septic shock, presenting with septic shock, or having female gender, and then having RV enlargement are also that. So in patients who achieved culture clearance, you can see here that there was an associated mortality benefit compared to those who did not have. Now, again, these patients had persistent infective endocarditis. So really, aspiration was the difference, right? Or perhaps made the difference, or was the salvage. And then finally, patients who had presented with shock had worse mortality at the 6-week follow-up compared to those that did not. So really, the key points were patients with right-sided infective endocarditis, the majority of whom were refractory medical therapy, percutaneous mechanical associated resulted in culture clearance, and culture clearance was associated with lower in-hospital mortality. Adverse events were acceptable, but and given the underlying right-sided infective endocarditis and the sicker population. But of course, we really need now randomized trials to confirm the safety and efficacy of PMA, and I think we're ready. We should be ready for that.
Thank you very much, Abdullah, for the great summary of the Clear IE registry. I think it's a start, and I think really looking forward to the continuing work by yourself and Sanjum and everybody in the country who are leading this. And I think Paul, I think we may have come to the end of the hour. I think we have one question in the QA. Do we have time for that?
Yes, I think you do. Question is, any experience removing subaortic masses in the LVOT? And if so, how would you approach it? Sanjay, Abdallah, any experience with that?
Yeah, so I'm going to turn over to Abdallah, but I think the concepts to think about are you're going to run into reach issues, and you got to think about whether you're going to go retrograde or transeptal. So it sort of depends on where it is. Are you talking about an apical LV thrombus? Are you talking about aortic valve vegetation that's subvalvular? So I think a little bit of that is going to depend on that, and Abdallah has definitely done a few of these, so I'll turn it over to him.
Yeah, so for these LVOT ones, you have to see on echo, look carefully if there's prolapse into the aortic space, because that helps. That's an advantage. Sometimes they flop into the aortic side. Really, the F18 angiovac, which is the 18 French angiovac, has been a game changer. You need to have an 8 millimeter diameter in the femoral arteries. You put a 22 French sheath, and you go up retrograde. It's about 100 length, so it reaches a nicely continuous flow. The other thing is, if it's subaortic, and it's not flopping into the aortic on the aortic side, you turn on the flows above the aorta. That opens up the aortic valve, and you just slide the angiovac underneath, and then ramp up and pull back and see if it goes. Last resort would be transapical, but those kind of would be the tips and tricks.
So you turn on the flow as you're crossing the valve to open
Yeah,
the
so
valve.
it opens the valve. You just turn
That makes,
an open
wow.
sesame. Yeah.
That is next level. That is
Yes.
fantastic.
That'll be we should do that, Paul.
Yes, try it.
Yes.
It's amazing.
That's
It works. Yeah.
Well, that is definitely in the spirit of CVI as an operators meeting, and we need tips and tricks like that to share. So we're at the top of the hour. This has been a wonderful episode of Nail It with Nadira. And Nadira, thank you so much for putting this together with Abdallah and Sanjam. It's been just fantastic, and I'm looking forward to seeing some more cases. And so we'll share more. Sandra, Nadira, Abdallah, and everyone, thank you so much, and please have a good evening. Thank you all.
Thank you.
Thank you so much for having us.